Choosing the Right Appliance webinar. Our program today is brought to you by the Wound Care Education Institute and made possible by a grant from Shield Healthcare. This event has been created to provide an opportunity for education related to clinical topics that affect the wound care market today. The Wound Care Education Institute was started by two nurses, Donna Sardina and Nancy Morgan. They had one goal in mind, to improve the management of wounds and ostomy for patients across the nation. WCEI currently supports over 20,000 alumni through their certification courses in wound care, diabetic wound care, and ostomy. Before we begin the webinar, I'd like to run through a few housekeeping items. For those clinicians wishing to receive educational credit, you will receive an email from WCEI within 24 hours after the webinar with instructions on how to obtain your certificate. Please be sure to check your spam folder. If you have not yet downloaded the handout for today's presentation from your confirmation email, you may do so now by clicking on the link in your sidebar. For those that are participating in a group setting, please click on the document titled CE Contact Our Group Participation Forms. Groups must submit these forms to receive educational credits. Again, this is only for group participants. If time permits, we will address questions at the end of the session. As a reminder, to receive educational credit for this webinar, you must be logged in to view the full presentation and view the slides. No credits can be awarded for those who do audio only. The planners of this course have declared no relevant conflicts of interest that relate to this educational activity. On-course learning guarantees this education is free from bias. And now I'd like to introduce you to today's speaker, Joy Hooper. As an RN with over 20 years of wound and ostomy care experience, Joy has practiced in a variety of hospital and home care settings. She's a successful nurse entrepreneur as owner of Medical Craft LLC and is board certified by the WOCN as a CWOCN and by the NAWCO as a WCC and OMS. Her informal and down-to-earth teaching methods enable students to learn easily in a relaxed and enjoyable environment. Joy is the lead instructor of our ostomy courses and also serves on the advisory committee for Safe and Simple. Welcome, Joy.
Hello, hello, hello. Thank you very much for that nice introduction. So let's start talking about ostomies. And today it's just all about ostomies. And as you can see, we're starting out talking about the appliance system. So we're talking about the pouches. But before we delve into the pouches, what I always get comments about is helping them understand the ostomy surgery better. So while we've still got some people logging in right now, let's take a minute and make sure that we all understand what these different ostomies that we're talking about today, how they're created. Now, if you've seen my webinars before, you know that I teach for this apron. So let's first take a tour through the GI tract. Then we're going to look at a colostomy, an ileostomy, and a urostomy. So we chew our food, it goes down our esophagus into our stomach. Then the food is slowly released to travel through the small intestine. It's traveling through the small intestine, it's being melted down by digestive enzymes, churned up by peristalsis and other muscular action, and that's helped to break down the food. And that's because the small intestine is where our digestion happens. That's where the jejunum, the villi and the jejunum are going to absorb the vitamins and the nutrients and take it to use for fuel for our bodies. After the food has traveled through the small intestine, it's going to go into the large intestine. And as that chewed up food travels through the large intestine, it's having the excess fluid extracted from it. So we can say the large intestine drinks for us. So small intestine eats for us, large intestine drinks for us. To help you understand today's surgeries, with a colostomy, the surgeon is going to separate the bowel, just like I've separated it right here in the colon. Then to create a stoma on the outside of the abdomen, the surgeon is going to make a small incision, just like I've made a small incision in the front of this flap. The surgeon is going to pull the open end of the bowel through that small incision and create the stoma. And this is how the person's abdomen will appear after colostomy surgery. They'll wear a pouch over it to collect that stool. Now, with an ileostomy, that is happening in the ileum of the small intestine. So with an ileostomy, the person has no colon drinking for them anymore. Their output's coming right off of the small intestine. It's the same stoma procedure where the surgeon makes that small incision into the front of the abdomen, brings the end of the intestine out, folds it over, and sutures it down. But you've got to make sure your patient understands they don't have the colon drinking for them anymore. So now the small intestine, the stomach, it's going to have to pick up the slack, and the only way it's going to be able to do that effectively is if that person drinks extra fluids. Now, another thing, the output coming out of that ileostomy stoma is going to be very caustic to the skin, and that's because of all those digestive enzymes that were happening right in the small intestine. Now, for my last demonstration, that's going to be a urostomy, and a urostomy's common name is an ileal conduit. That can be very confusing for some people, but actually it's a really good name because they're going to use part of the ileum for this. Watch me explain a urostomy. With a urostomy, many times we're seeing this for bladder cancer. There seems to be a rise in bladder cancer now. So what the surgeon does is actually removes the bladder. Now, the surgeon could, if needed to, completely bring these ureters out of the body and make ureterostomies. But the problem is ureters tend to stenose, so that's not a really good idea. What the surgeons more often do is go to the end of the ileum and they remove a section of ileum. Then they connect the GI tract back together like it never happened. They take this little piece of ileum right here and they create what's known as a conduit out of it. Now, a conduit is something that carries something from one place to another. And in this case, it's going to carry the urine out of the body. So the surgeons are going to connect the ureters into this little conduit of small intestine, close off one end of it, and then they're going to do that same stoma procedure, usually on the right side of the body, and this is where the urine now is going to drain from the body. Now, something you want to make sure that the patient understands, this piece of GI tract doesn't know and doesn't care that it's no longer part of the GI system. Now it's part of the urinary system. So it's going to keep secreting mucus. So the person with that urostomy pouch can have a lot of mucus sitting right there in that pouch. Now, I hope that helps you understand these different stomas as we go through the rest of this presentation. So as I mentioned before, we were talking about the appliances. And when I'm saying appliances, I'm talking about the actual pouching system itself. And this is used for our our incontinent ostomies, all of which that I just showed you. These pouches, these appliances are going to collect both the gas and the feces or the urine that comes out of it. We usually call the output that comes out of an ostomy effluent. Now, for our categories of the appliances, we've got two-piece systems where you've got your pouching system and then your skin barrier, or we've got one-piece systems where everything is made together in one piece. And we have this two-piece, one-piece system that's available for both your urinary or your fecal pouches. And then there's several more features in each of these categories, being one-piece or two-piece. You can have different closures on the bottom. You can have Velcro that rolls up on the bottom, just like I showed you in this one right here, a Velcro closure. Or with the urostomy, it's going to be more of a spout type closure. Or of course, we could be talking about a good old clamp either. Now, you've heard me say appliance, you've heard me say pouch. When I'm talking about an appliance, I usually use the term pouch rather than the term bag. And I think it's because every time I hear somebody talking negatively about an ostomy, they're using that term bag. So I just like to come at it with more of a positive outlook, so I prefer the term pouch. Pouch. But we could also use appliance when we're talking about the entire system. What is the person using? What's their appliance? Like I said, pouch, to me, it just kind of gives it a negative connotation. So, or the word bag is a negative, so I like the word pouch. Now, you also heard me say skin barrier. When I'm talking about the skin barrier, I'm talking about what we used to call the wafer. Years ago, it was actually called a face plate. But now we're trying to get on the same page and call it the barrier. But don't get confused when I use that term barrier. I'm not talking about your skin barriers, you know, your products, your polymer products that go on the skin. Now, as we get into these different appliances that we're looking at, you've got to think, what am I looking for when I'm looking for the pouch that's right for my patient? Well, it should be able to meet the goals that you're wanting. Number one, it should be able to offer that person security in the sense that it offers them a reliable, predictable wear time. And we would like that wear time to be at least for 3 days and not over 7 days. You know, when it comes to wound care and ostomy care, we like to take a look at the skin at least every 7 days. So we don't want the pouch being left on the body over 7 days either. Other goals, we want this pouching system to be comfortable for the patient. We want it to move with the patient, not interfere with their lifestyle. So we want it comfortable. We also want it inconspicuous. We want it as low profile as possible. It needs to be easy for this person to empty, remove, and replace as well. Now, another big goal that's very important when it comes to choosing the right appliance for your patient is it's got to be odor proof. And pouches today are designed to be odor proof. And as long as all the stool is inside the pouch and not up around the flange or down at the bottom where it's to be emptied, the pouch should be odor free, But sometimes when people empty, they don't cuff the end of the pouch or they don't clean the end of it well, and the little bit of residue is left at the bottom of the pouch. All it takes is a little bit of stool to make a big stink. So make sure you're cleaning that pouch really, really well after you've emptied it. Other goals for that appliance? Well, it needs to protect that peristomal skin. The peristomal skin is the skin that's right around the stoma, and we're expecting this pouching system to adhere to that area and provide a good barrier to the skin. That's why we're calling it a skin barrier. Another thing, we're expecting it to be cost effective. And what you're seeing right here on this slide is we have a large area of peristomal skin irritation. And what they've chosen to do is use one of the fistula type pouches to cover that large area of denuded skin, as well as to collect the output that's coming out of the stoma. And you can do that with products like fistula pouches. And you can see in just a couple of days, we got the outcome that we were looking for. Now, you know, we've got to have a good fit when it comes to these appliances. That's going to help that person, you know, get back to their new normal. There's a lot of different considerations when you've got different appliances to choose from. Sometimes it can just be overwhelming because there are so many choices out there. You know, just be calm, be systematic. Think about what you're looking for. To start out with, you want to make sure you do a really good, complete stoma assessment on your patient. Have a good stoma assessment form that's going to have what type of ostomy they have, the size of their stoma, the location, you know, what quadrant of the body is it in. Note how that peristomal skin is. Is it intact? Is it denuded? Does the person have candidiasis, a yeast-type fungal infection of the skin? What about the shape of the stoma? Is the stoma round? Is it irregular? You know, that makes a big difference too, so you want to note that. You also want to note the protrusion of the stoma. This is going to help guide you as to using a flat system or whether you're going to need a convex system. And also note the complications that the person is having. You know, do they have leakage at night? Do they have leakage all the time? Is their skin itchy? Is it burning? Is it that nothing will stick to them? All in all, make sure that you do a good, complete stoma assessment. Other things that need to be assessed are who's caring for the stoma. Is it the person that has the ostomy, or do they have a caregiver? And if they do have a caregiver, you want to make sure that your instruction is going not just to the patient, but to that caregiver as well. And whoever is taking care of this person, how's their dexterity? Do they have good manual dexterity? They can use those curved tip scissors and cut through convexity. If you know, during the time right after the surgery, the post-operative period, the stoma size is going to be shrinking. So you want somebody that's going to be able to cut that skin barrier out. Well, some of your convex products are thicker and they're harder to cut. So we may want to help that person who has problems with dexterity by getting them a moldable system, if at all possible. Is there any visual impairment? If there is visual impairment, what kind of visual impairment are we talking about? Is the person blind? You know, in that case, we want to have everything already done to that pouch when they get it, you know, as much as possible, like pre-cut, closed-ended. So there's less things that the patient's going to have to do. Or does this person simply have poor vision? And we want to order pre-cut pouches for them because they can't see to cut out on that line. Or is it a situation where the patient is not able to look down and see their stoma? Is that the issue? So whatever it is, we got to figure out why can't they see it, and let's see if it's something that we can work around. Other physical considerations that we need to consider, you know, does this person have any cognitive impairment? If they are they the ones that is doing most of the management of this ostomy? If it is, we want to get them in as simple an appliance as possible. Are we dealing with a lot of moisture? I live in South Georgia, and down here, humidity is a way of life. So people with an ostomy down here have to make sure that they're wearing a pouching system that is able to absorb excess moisture on their skin. We tend to use a lot of the standard regular wear products down here. But sometimes it's just episodes of humidity. Maybe they work in a hot factory, or episodes of sweating. Maybe this is a woman who's going through menopause and she's experiencing hot flashes. You know, we need to make sure that our patients know what to do in the event of sweating. What can they do to help that skin barrier stay on longer? Other social considerations, we have to consider that person's activity level. If this person wants to participate in sports, we want to help them participate in sports. We want an appliance that's going to adhere well to their body, and maybe we're going to introduce them to some type of solidifying agent that's going to solidify the stool for that person with an ileostomy so they don't have as much slosh, right? So we got to think about those sports because we don't want to interrupt anybody's sports schedule. We've also got to think about the financial considerations. Is this person self-pay and they're having a hard time meeting that deductible? Maybe they're not getting the right amount of supplies that they feel like they need each month, or maybe they have no income at all. So maybe we're going to need to locate some pantries around the country that can help this person at little or no cost get their supplies. Social considerations, we have to take a look at those as well. You know, in some religions, you get into different postures to pray. And if this person is down on their knees, you know, with their shoulders close to the ground as well, getting in that praying position, we want to make sure that we have a pouching system on them that's going to accommodate their knees and their chest in this position. So talk to your patients about, you know, do you get in a certain position? How do you pray? Just tell them openly and honestly, I may not understand your religion, but I understand ostomies. And the last thing I want is for you to have a leak in your house of worship. So let me work with you, and let's make sure that you've got a really good seal on your pouching system. Let's make sure it's a pouching system that's going to move and give with your body, so you've got that perfect fit for you. And intimacy. Intimacy is something that we need to discuss with our patients as well, because getting back into the swing of things, so to speak, with an ostomy, after ostomy surgery, it can be very intimidating. It can be very scary for for that person who's just had ostomy surgery, and even for their significant other. So introduce them to different belts or binders to help hold that pouch into place, or even conceal it as well. Nutrition. We need to talk to that person about nutrition. Do they have foods that they just don't tolerate well? Things that seem to run right through them, or things that cause blockages for them? We've got to keep an eye out on that. The UOAA has multiple downloads. If you go to their site, there's multiple downloads for foods that can make your stools not as thick, or stools that can make them less thick or more thick. However you need to manipulate your stool, that's what I'm saying. They've got lists of foods there for you. You know, somebody with an ileostomy may look for those foods that can help thicken up their stool, but somebody with a colostomy, well, maybe they're experiencing something as like constipation, so they need to know about the foods that can make their stools not as thick. And usually we're talking to everybody about the amounts of fluids that they're drinking, and we're trying to encourage them to drink more. I showed you with the apron that the person who has an ileostomy, they don't have their colon drinking for them anymore. So they need to be drinking extra fluids so that small intestine and stomach can compensate by absorbing additional fluids. And also recent weight gain or recent weight loss, that can affect the way the person's pouching system affects. It can affect the length of wear. It can affect just the way that it fits their body, all from weight gain or weight loss. It can definitely affect the shape of the stoma as well. When you gain weight, sometimes the stoma will go from being perfectly round to more oval shape. This is going to affect that person who has their pouches pre-cut. So we got to watch out for the weight gain and the weight loss. Another question that you want to ask that person is, what type of appliance are you currently using? Are you currently using a 1-piece or a 2-piece? And do you like that? That's what I want to know. If they're happy with that 1-piece, I want to keep them in it. If they're happy with a 2-piece, let's keep them in it. But if they're not happy with it, let's make some changes to it. And then see what other changes need to be made as well. Does this person need flat? And when I say flat, this is what I'm talking about. A skin barrier that's just flat on the back, as opposed to one that's more bowl shaped like this. You can see how this is convex, all right? It's shaped for those flush or retracted stomas. Does the patient want something that's cut to fit? Cut to fit. These have the little lines drawn on the back that are going to help you cut this out. Now, some of them don't have the lines that are on the back. They're, you're going to use that little template, a measuring template, kind of like this with it, to help you make those cutting, specific cuts to fit that stoma perfectly. What type of pouch are they using? Are they using a clear, or we also call that transparent pouch? Or do they want something that's opaque, something that you're not able to see through? You know, after the person has had the ostomy for a while, they know what's inside and they may not want to see it anymore. So they may want to go with something called opaque, that you're not able to see through the pouch anymore. Right? Just whatever the patient wants. And then you see it says disposable liners. There's different liners that you can put inside the pouch and use them with the same principle that you put a trash bag in your trash can. Kind of lines that trash can. Well, a liner is going to line the pouch, and when they go to empty the pouch, they're just going to take that liner out, throw it away, and put another liner in. So that helps somebody not only cut down on the uses of their pouches, that helps that person who isn't dealing with that ostomy output very well either. And then you see something called a stoma cap. A stoma cap is actually a very small pouch. Here's an example of a stoma cap right here. Very, very small little pouch. What these are designed to be used for is the person who does colostomy irrigation. They would wear this over their stoma because there could be mucus that comes out of that stoma. Yeah, they're not expecting output because they're doing colostomy irrigation. Okay, also, how about some extra adhesives? Is the person having problems with things sticking to their skin? So they feel like they need extra adhesives. First off, if they feel like they need an extra adhesive, they don't want to reach for something called paste. And I know that's what it sounds like you would want, but paste is actually not an adhesive product. Paste, when we're talking about ostomy paste, is actually a caulking product. If you want adhesives, you want these little moldable type rings right here. And when you use a ring like this, make sure that you allow it to come to body temperature. Now you can warm these up between your hands, just maybe 30, 45 seconds. It's going to make it nice and soft. It's going to make it more pliable. It's like warm Play-Doh. But the best thing is it does stick to the skin. There's adhesive technology that's made right into these rings. These rings are available by pretty much all the different large manufacturers, and they're available in a large variety of different sizes. Now let's go ahead and pull the outer pieces of plastic off, and you can see that this ring can just be stretched however I want to stretch it. I can even roll it up into the little snake form if I wanted to. Yeah, there we go. Some people like doing it like that. So whatever is going to work. But the great thing about the rings, like I said, they are adhesive. So I feel the tackiness on my hands. Other accessories that the patient may need to help get that good seal. Well, what about a belt? You know, a lot of people like these little belts. These little belts, most people get one of these a month with their ostomy supplies, and you wear them with the systems that have these little belt hooks right on the side. Now, there's an example of it. Now, some of the newer versions of these products have a different kind of belt, where this belt had the one hook on each side. Some of your newer ones actually have two hooks. And so we're looking at a Coloplast Mia pouch right now and skin barrier. And you see it's got the dual hooks on either side. What that's going to help with is if that person has a hernia creates a large bulge on their abdomen. This just gives a different type of security that allows it to pull down from 4 different points rather than 2 different points. Everybody's abdomen is different, so it's worth knowing about tons of different supplies to get that perfect fit for your patient. Other things that we're looking at on this slide right here, talking about lubricants. Now, when and why would you need a lubricant? A lubricant can help you when it's time to empty the pouch. If the person has a colostomy and their stool is really thick, it can be hard for that output or that effluent to be emptied out of that pouch. So a lubricant that's going to coat that pouch and facilitate the ease of emptying would be a wonderful product. Whenever somebody does want a lubricant, we want them using the manufacturer's suggested products. We don't want them going off the reservation with something like baby oil or mineral oil or PAM. Those products can actually cause the seals to fail. What I mean is when the person lays down at night and the effluent runs up and sits right on top of where their stoma is, the PAM, the baby oil, can actually cause that seal around that stoma to loosen up. And that's the last thing that we want to happen at night. So we want to stick with the lubricants that we know are safe to use in the pouching system. They say that there's some type of molecular breakdown whenever you use some of the products like mineral oil or baby oil in the pouch rather than the approved, or I shouldn't have said the approved, rather than the manufacturer's type products. For odor control, odor is a big issue, and here's a couple of products I happen to have on hand for odor. You can put products in the pouching system. You can spray sprays in the toilet to help mask the odor. Or you can spray in the air. So there's different products that you can use. For the ones that go directly into the pouch, you have drops, you have powders, you have liquids, and you actually have little sachet products like the product Diamonds. This one actually helps with odor control, but it's also a solidifier. If you have an ileostomy, you can drop one of the little Diamond sachets in your ileostomy pouch, and that's going to help solidify that output. So let's say you're running and you, with an ileostomy, you might have that slosh, slosh, slosh from that liquid stool. Well, the Diamonds, and there's also a product called Parasorb, a product called Pearls that does the same thing. It's a solidifier, and it's going to turn that liquid into a gel so there won't be so much sloshing going on. It also has a deodorizer, so that's going to help when it comes time to empty that pouch, help combat that odor. Other accessories, you know, some people want to wear that transparent pouch, or maybe they just ordered 3 months worth of transparent pouches, but yet they really don't want to see what's going on inside. So there's different covers, like pouch covers. There's different belts that actually house the pouching system. That would be Stealth Belt is one of them. And there's a couple other companies that have belts that actually house the pouching system. And you also see the stoma stifler right there. The stoma stifler is a muffling type of product, and you wear it with a belt, or you can tape the magnet to your skin. The stifler actually goes over the stoma to muffle the noise. So let's say this person is in church for a service, maybe a wedding or maybe a funeral. Traditionally, churches are quiet environments, and when we have that sound that comes out of that stoma, it just seems like everybody hears it. Well, having a device like the stoma stifler would help muffle that noise. Now, if the person doesn't have a stoma stifler, you can tell them simply to put a shawl or a coat, a cape, a lap blanket over their abdomen. That would help muffle it. And then, of course, if that noise does come out, well, I tell my people, just kind of look at that person in front of you and look away, because nobody's expecting that sound to come out of the front of somebody. They're expecting it to come out of the back of somebody. So, hey, no problem with passing a look when you need to. Next thing we want to take a look at is, how is the fit of the product that they're wearing? You know, is the opening cut appropriately? We want 1/8 of an inch in between the skin and the stoma, or I should say the skin barrier and the stoma itself. 1/8 of an inch, that's all we need. Just enough space so the stoma can move with peristalsis if it needs to, but not so much space that we've got too much skin that's going to be unprotected. We also don't want that opening too small either. If it's too small, there can be friction irritation that can cause damage to that stoma. How is that skin barrier adhering to the skin? Is it fitting well? Is there leakage? How much erosion is on the back of that skin barrier when you remove it? You know, teaching somebody to remove the pouching system and then take a look at it, hey, it takes a while to get used to doing that. And the first time the person does it, they can feel really embarrassed if somebody else is looking at the stool on the back of their old pouch. But what you're looking at on the screen, that was a pouch that was just pulled away from the skin, and we're showing the person where the erosion was on the back of that skin barrier. That's something that you want that person to note, because that's a lot of erosion that you're looking at right there on that picture on the slide. We don't want to see that much erosion. Because if you have that much erosion, the part that eroded away, it was damp, and that was in contact with the person's skin. So I would expect the skin that pouching system came off of, with the back of the skin barrier that we're looking at, to have some erythema, some areas of redness right around the stoma. Note that person's topography, you know, that person's abdomen. Do they have creases? Do they have scars? Do they have other incisions or hernias on their body that give it this irregular topography to it? You know, we want a flat pouching plane as much as possible. Also, how is their skin dealing with that skin barrier that's been in place? If you look at that top picture, that doesn't look like they're dealing with it very well. That skin looks denuded and it looks very painful to me. Maybe this person's actually allergic to the system. Another issue is they've got stomas that are close together. So the skin barriers would overlap. That can be a problem when you're dealing with it as well. And then as we look at this picture, every time I see this picture, the first thing I think of is, ouch. That's got to be terribly uncomfortable for this person. When they're having leakage, where's the leakage coming from? Is it coming from up underneath the skin barrier or from the pouching area? That's what you need to decide, because it's going to be two different fixes. It looks like the picture here, it's coming from up underneath the skin barrier, and it looks like one of those cases where it just got so bad, the person gave up and went without that pouching system for a while. We have that a lot of times with people that have ileostomies. They'll feel like their skin gets so raw that they just need to air the skin out. Well, no, we don't want the skin to air out. We want to protect that skin by having a good fitting pouching system. As long as we can contain that effluent in a good fitting pouching system, that's going to keep it up off the skin. It's those digestive enzymes from that small intestine that just love to eat that skin away. So we want to keep them in the pouch. Do they leak mainly at night? If they leak mainly at night, maybe it's a situation that when they're laying down, maybe their stoma flattens out more. Maybe their creases flatten out more. Your creases in your abdomen change with the way that you move. If you lean back right now and put your hands on your abdomen, might feel pretty good. Now lean forward. Now when I did that, I felt multiple contours happen in my abdomen. Well, our patients are the same way. So there are positional changes. We need to figure out when and where they're leaking the most. Is friction causing a problem with their current pouching system? We're going to know that by taking a look and seeing where the skin folds are, checking the edges right there of that skin barrier. See if they've been digging in the skin like it looks like those have in the picture above on the screen. How about their wear time? What's their wear time with that skin barrier? What's the wear time with that pouch? Are they not wanting to change this any more than they have to? Maybe they just change it whenever there's a leak. We don't really want that. We want the person to stay on top of the pouch changes. Maybe they're going to change it on Tuesdays and on Fridays. They're going to develop a schedule for what works best for them. And then that way they're going to be easy. It's going to be a lot easier for them to know when those unscheduled changes are. Was it because of odor? Was it because the skin barrier just started leaking? Was it because they didn't like the way the pouch started looking really bad? What's their issues? Why are they making unscheduled pouch changes? And emptying. Are they having any issues with emptying? Are they able to empty appropriately? Do they know that they need to empty that pouch when it's 1/3 full? Hey, that doesn't sound like it's very full, but you got to think about 1/3 full. There is going to be a lot of weight in that pouch. This pouch is stuck to the body by something similar to a sticker. And when you think of weight, something stuck to the body like a sticker, and gravity, all those factors just want to pull that pouch away. So we don't want it any more than 1/3 the way full. You also want to work with your patients about emptying it. Is it something that's easy for them to do? Do they have problems manipulating the bottom of the pouching system? If they do, let's get them in Velcro or get them in a clamp that's going to be easy for them to empty. We want to teach them how to clean the end of that tail after they've emptied it as well. Now, some people like to rinse their pouch. Some people don't want to rinse their pouch. I prefer that my patients don't rinse their pouch. The reason is it introduces water, liquid, up into that pouch that can cause that seal to start eroding away. So that's the only reason I'm against, rinsing a pouch out. I would rather the person wear something opaque that they can't see the pouch and not have to worry with that soiled inside of it. What's the patient's preference? You know, is their current system meeting their needs? Are they comfortable with it? If they're comfortable with it, the last thing I want to do is take it out and take it away from them, try and get them to use something else. But if they're not happy with it, maybe they don't like the way it feels on their body. Maybe they don't like the way that you can see it up underneath their clothing. Well, I'm going to make some changes. You know, there's a couple of different colors of pouches that we can reach for when we're looking for opaque. We've got your tan color and we've got more of a gray color. So there's options. There's also many options about the sizes of these appliances. You know, there's small, there's large, and there's extra large when you're looking at the different sizes. And the profile. Some of these are going to be very low profile to the skin. Of course, that's going to be usually you're talking about your one-piece system. That's going to be your most low profile. But even your two-piece systems can be pretty low profile. You're going to lose some of your profile with two-piece systems because you've got two different pieces connecting. But some of these still can be pretty doggone low profile. How about the direction of the pouch? Some people actually like to wear their pouch turned to the side. Now, when I think of wearing the pouch turned to the side, I think they're doing that to wear a specific type belt, like the stealth belt. But actually, what I found is some people just like to wear their pouch to the side because they don't like it dangling down their leg or hanging down into their underclothes quite so far. So whatever is right for that patient, it's right to do as long as it works. Again, with the effluent concerns, you know, do they feel like their pouching system they're currently using is too small? Let's get them in something bigger. Is there a problem with odor? Make sure that they know that pouches are designed to be odor-free. So as long as the tail is clean, as long as the flange part doesn't have any stool in there, there shouldn't be any odor. And for your gas, you know, there's different vents that can be added on, or there's filters that are on the pouches that can help with that. They can also help with pancaking as well. Pancaking is when you have a buildup of stool behind the skin barrier that won't go into the pouch, and that happens because a vacuum has been created. Some people with urostomies like to use bedside drainage. This can be a sleep saver right here. If you have a urostomy, you may have to get up during the night and empty that pouch, but if you connect to a bedside drain, that urine is just going to flow from your pouch right to that bedside drain, giving you a lot longer sleep time. Now, you do want to make sure that it's secured well, and I actually prefer that my patients drop their bedside drainage bag into a little trash can. You know, just get you a very inexpensive bedside trash can. That way, if it opens accidentally or you have to grab it and run to the bathroom in the middle of the night, well, you're just grabbing up that trash can, not having to unhook it from the side of the bed. Peristomal skin care. We want that person caring for that peristomal skin, shaving any excess hair away. And when I say shave, hey, think about using a trimmer, not that straight edge razor that you're looking at on the screen. Just those little trimmers that you can buy from the beauty supply store or the drugstore. Most of them are under $20. That's going to be really good for the skin as opposed to that straight edge razor. You don't want the person shaving more than once a week. And there's other ways to remove that hair. You can use products like Neat or Nair, your depilatories, or you can even look into laser therapy. There's a couple of men that have used laser therapy to get rid of that hair around the stoma, and they say it's worked like a charm. Bathing, showering, we still want that person to be able to bathe or shower after ostomy surgery, but there's some little tricks that can help them along the way. You're looking at a product down there on the bottom called a stoma cup. The little stoma cup helps that person who has a urostomy or an ileostomy by when they get out of the shower, they can grab that stoma cup, attach it to their body with a belt, and then they're able to take both of their hands and dry themselves off. Because when you think about it, when that person with an ileostomy or a urostomy gets out of the shower, they're going to have to use one of those hands to hold something over that stoma to collect that effluent from running all down their body. But if they have that little stoma cup, like I said, it attaches with a belt, then you put a little cotton or a little toilet paper in there, and that's going to absorb any of the effluent that comes out. If this person has a colostomy, they might be a candidate for colostomy irrigation. A colostomy irrigation is like giving yourself an enema, and that's going to make the stool empty out of the distal end of the colon, and the person simply wears a little stoma cap to collect the mucus because they shouldn't have any output that would necessitate them using a regular ostomy pouch. Now, does the person have any activity restrictions, any pouch limits, any issues with security, any issues with odor? You want to ask those questions so you can meet that person's needs. Let's look at some solutions. When we've got somebody that has a poor vision, poor dexterity, and they're not going to be able to cut their pouching system out, let's see about getting that pre-cut skin barrier. It's pre-cut to the size of that stoma. If their problem is they're just unable to visualize their stoma, maybe it's a woman with pendulous breast, well, just like the guy with the picture right there, he's using a mirror to be able to see his stoma. I guess he's not able to see over that ripped ab. I guess it is right there. Whatever, I'm not judging. I'm not judging. If they've got issues with dexterity, like I said, we could go with something pre-cut, or we could even use a moldable type product. Your moldable products, the part around the stoma is moldable. You're actually going to roll it back with your thumbs. I'm rolling it back. And then in time, it's going to roll back up right around the stoma. Now, your moldable skin barriers, they are able to roll back up and touch that stoma. You don't have that 1/8 of an inch that's needed between your more rigid type skin barriers. So there's lots of things that we can do for somebody who's got dexterity issues. And another thing is the adhesive coupling. The adhesive coupling system uses adhesive rather than that Tupperware type flange. The skin barrier and the pouch stick together just like that. All right. Adhesive coupling. And the great thing is you're able to pull it apart and stick it back together several times. Look at how flexible adhesive coupling is. So another great idea for you. If they've got that flush or retracted stoma, of course, convexity is going to be the name of the game. We don't want that flat skin barrier if we've got that flush or retracted stoma. We want something convex, and here you're looking at the application of convexity. They put one of those moldable barrier rings right there over the incision of their abdomen. They've taken some paste. Their paste was pink, went around the stoma, then they applied a ring, and then they put that convex barrier right on top of it. We were talking about the belt a few minutes ago. This is the one that I showed that has the 4 prongs on the side to help pull that skin barrier down around maybe something like a peristomal hernia or very irregular skin. If you've got those deep peristomal creases, I recommend using the rings just like you're looking at on the screen. So those moldable barrier rings, this is the one that I snaked out a few minutes ago. You can mash them, you can squeeze them, you can mold them together to go wherever you need to. And you can stack these up. You can use 2, 3 rings. You can use a half of a ring, then put the other half up. Use it later on. If you've got multiple skin wrinkles, think about that flexible system. Maybe the thin moldable barrier, strips, or rings on your patient. Those deep gullies, those defects, we've got to fill those in. So again, think of some people like paste. Think of your moldable barrier rings, or even strip paste. There's strip paste up at the top of the screen. For that soft, flabby abdomen, that firm faceplate, belts, binders, and for that flabby, soft abdomen, you may want to use a belt again for that added security. If the person has problems with moisture, We definitely can recommend some types of antiperspirants. These antiperspirants are aluminum chloride hexahydrate, and you can put them on the skin up underneath the skin barrier. They're antiperspirants. They're not deodorants. Antiperspirants to help the person not perspire. Now, you only want to use those on intact skin. You don't want to use those on denuded skin. Something else I recommend if the person's sweating a lot, that's going to be the standard wear skin barrier or the regular wear. Stay away from your extended wear product because those are more moisture resistant. Now, a lot of our patients, it says as many as 50% of our patients are going to have issues with peristomal irritant contact dermatitis. But what we want to do is keep that effluent off of the skin. We want to check for leakage when we see that irritant dermatitis. And you're looking at a picture right there where they're showing the patient the back side of that skin barrier. They're saying, hey, take a look at the back side of this skin barrier. You can see where there's been some wear on your skin. And what that person is probably thinking is, hey, there's a pile of stool on my skin. I want you to get that stool off my skin. Well, tell that person, I know you don't want stool on your skin, but I can see down at the bottom of this skin barrier, there's been stool on your skin for about a week, dude. It's been building up. Show them the back of the skin barrier. Make sure they see the correlation with their skin. Make sure that they see that. So when we see these wear patterns on the back of the skin barrier, see where that was on our body. Many times we can see that's where the stool was pooling up underneath it, or the skin barrier was eroding away. Now, something that I like to show during these presentations is how to do something called crusting. And I'm going to show you crusting with some products that I've got here on hand, but I want you to know that there is a video on YouTube, and if you'll just search YouTube with the words crusting and ostomy, it should bring you up to one of my free YouTube videos that talks about crusting. Crusting creates an artificial scab, and why you would want to do that is you can create an artificial scab, stick the skin barrier to that artificial scab, and then when you lift off that skin barrier, all you're lifting off is that scab. Now, to make a crust, first we're going to put powder down. After we put our powder down, we're going to take our skin barrier and we're going to dab this area. Now, if you have a spray, of course, you can spray the skin barrier on there. All right, so that's my first layer of crust. I put down the powder, then I put down the liquid skin barrier. Now, of course, on my patient, I wouldn't be fanning, but I'm just trying to expedite the process right now. So I'm putting more on there, more powder, and more liquid barrier film. I can use that. I could use my little prep right here. But that is creating a crust. Now, you only want to use crust on the denuded skin. This is not a protective procedure right here. It does not use, I'm sorry, it is a protective procedure. It's not a preventive procedure. So we only want to use this when the skin is raw. It's not something that we want the patients to do all the time. If they were having some type of yeast type candidiasis issue, they could certainly substitute a nystatin or an antifungal powder for your standard ostomy powder that I showed you using. Some people build up 2 to 3 layers of crust. Some people even build up 4. I'm typically a 2-layer kind of gal, just 2 layers for me. Again, you want to put the skin barrier powder down. You want to put your ostomy powder down first, and then you're going to apply the skin barrier, either prep or spray on top of it. And this is showing all the steps of it right there. So I moved through that pretty fast. If you need to go back and reference the video on that, go right ahead. Now, I'm going to take some questions in the next few minutes, but to talk about different resources that are out there for you, first one I want to mention, Shield. Shield's got a great booklet on life with an ostomy. So Shield is a great resource for us. All your manufacturers are great resources as well. And something that you might not have thought of, you becoming a resource You know, here in the United States, we've got 2 different pathways that you can choose to become an ostomy certified clinician. There's WCEI, Wound Care Education Institute, or the pathway of the WOCN. And you know what? We don't care which pathway you get on. You just get on that pathway because we need more certified ostomy clinicians here in the United States. So check out both of those websites, find the pathway that works best for your life, and please get on it. We need more certified clinicians. So let me end this by saying your patients can find confidence in that confident fitting pouch system. We want to give them that reliable, predictable wear time. That's what it's all about, finding that right appliance. I want to say thank you to Shield Healthcare for sponsoring this webinar. And now let's open it up for any questions that we might have. All right, questions?
Hi, Joy. This is John Maynard, Product Manager at Shield Healthcare. Thank you so much for your presentation.
Sure thing, John.
Really informative as always. We had a lot of questions come through throughout your presentation. One question that certainly popped up a number of times, and you covered it in your solutions section, but I just want to reiterate it. It was, could you please explain more about which barriers to use in human environments? Which barriers absorb more moisture?
I sure will. Okay, so which ones absorb more? That's going to be your regular wear or your standard wear. Those have the ability to absorb the sweat, the moisture from the skin, like raw skin, you know, raw skin weeps. So your regular, your standard wear are capable of absorbing some of that moisture. Your extended wear products aren't as absorbable, okay? They don't absorb, they are resistant to that absorption. You want to use those typically with your ileostomies and your urostomies when you don't have any denuded skin issues. That help, John?
That's great. Thank you, Joy. We also have another question. Someone chimed in, said that they're seeing more soft convex items from manufacturers. Are you seeing more patients with a need for convexity?
Yes. So you say there's more soft convex products on the market. Yay! First, let's say that, because unfortunately, we're seeing more of a need for convex products. And one of the reasons that I see more of a need is I'm seeing more loop stomas. A loop stoma is a stoma that they pull a loop of the bowel out. It's usually got some type of stabilization rod up underneath it that's going to stay in place for about 7 to 10 days, and then they're going to remove that. Now, with a loop stoma, what they do to allow the stool out of the body is they make an incision in that little loop. And most of your loops, not most, but many of your loop stomas are flush or retracted to the skin. And so that itself lends itself to want to have something like that convex product.
Got it. Thanks, Joy. We have 2 more questions. We have time for 2 more questions?
Sure.
Fantastic. One question we had that didn't come up in your presentation was from Misty, and she asked, what about techniques to accommodate larger abdomens and to accommodate women who are pregnant?
One thing that I would want to use on somebody that's pregnant, just take that out. One thing that I like to use are products that move and give. You know, as that baby starts getting bigger, that abdomen's going to start moving. The Coloplast Mia actually has a little bit of stretch and give with it. So pregnancy, hernias, I like the Mia product because it has a little bit of stretchability to it. Sorry, I didn't mean to kick the computer. It has a little stretchability to it. And it's not just with their pouching system. The flange, the elastic flange barriers or elastic barrier strips, these are also very stretchable. So for that person whose abdomen is moving, like the pregnant mama or the person with a hernia, if we use a lot of extra tape on the skin, the tape can strip the skin. But you can see these have a lot of stretchability to them. So maybe these would be a big help. Elastic barrier strips is what they're called. That help, John?
That's great. Thank you, Joy. Listen, I think we've now reached our 1 hour mark. I really appreciate your presentation, Joy, and thank you for everyone for attending and listening. This presentation has been recorded, so it will be available. If your questions have not been answered, we will be able to respond to your questions individually. But once again, I'll turn it back over to WCI in case there's any additional housekeeping issues that they want to cover.
All right. Again, I would like to say thank you to Shield for sponsoring this webinar. And anything else that we need to cover?
We're good on our end. So thank you, everyone, so much for attending. We really appreciate your participation, and we look forward to working with you and having you attend future webinars.
Thank you, everybody. Happy pouching to all. Thank you.